Thank you, everyone. I will not be including flamenco dancing this year, so no worries about that. When Katie and I were talking about how I might be able to contribute today, we were thinking, how much is it that people actually get a chance to learn and understand what neuropsychological testing actually is? And I realize that probably many of you in this room have had some experience, either directly or indirectly, or exposure to this concept of neuropsychological testing, either through clinical efforts or research efforts. But we thought maybe it would be helpful to take a step back and understand what this actually involves, since many of our loved ones here actually have gone through the process. So when I introduce myself as a neuropsychologist, people kind of look at me and scratch their heads. They have these very unusual ideas about what a neuropsychologist is. They get images of some Freudian doctor who's going to sit you down and talk about your mother and your childhood. They have ideas about what we're going to do to your brain. Are they going to stick electrodes in the brain? Am I going to do imaging? Am I going to do EEG? Some people wonder, is this the same as a psychiatrist? Or are you going to give me medications? So really the question is, what is neuropsychology, and what is it that we're actually doing with this? So I think of neuropsychology as the study of the behavioral expression of brain functioning. And from a clinical and research perspective, we do this best right now through paper and pencil tests that are meant to be objective and created and normed on a large population. Hundreds and thousands of people have actually taken these tests, and that's how we understand what normal performance is on these, and then we end up being able to compare a patient's performance to that normative sample. And now we're moving more and more into using computerized tests to assess cognitive functioning. So some of the aims of assessment, we're trying to quantify changes in cognitive functioning. Patients will come into the office and say, I'm having problems with my memory, or I'm having a difficult time finding the right word. And that can mean a number of different things. You can have memory problems because you're not paying attention as well as you used to. Or you can have language problems because you either can't get the word out or you're losing the meanings of words. You can have memory problems such as I'm walking into the other room and I'm forgetting why, which, for most of us, I can say for myself, I'll walk down the hall about 10 times and forget why it is that I'm doing that. And understanding what that actually means, what's actually contributing to that problem, and what can be, if possible, done about it. From that evaluation, then we can actually describe somebody's cognitive profile of strengths and weaknesses. And based on that, that can actually help somewhat with clarifying diagnosis. As many of you know, different phenotypes actually present with different profiles. You may have a frontotemporal disorder that is preferentially affecting organization, planning, mood, apathy, inhibition, all right? So that would actually present with a profile that affects all of those areas on testing, as opposed to a profile that's more preferentially affecting language. So this type of profile is actually useful and one piece of how we can actually help clarify and quantify these changes. Another thing that happens is that once you get an assessment of somebody on all of these objective measures, you now have a benchmark. It may not be a true baseline in the sense of this is a picture of what you were like 10 years ago, 15 years ago, but at least at this point in time, this is what you look like on these measures. And so now I can actually track you over time. In 1 year, in 2 years, in 5 years, if I repeat the same tests, I can actually objectively compare old testing with current testing, updated testing over time, and actually see a very nice change potentially. Can be improvements or declines, but at least that will also help us clarify what that cognitive profile really will look like and how it might evolve. And the most important thing from my perspective as a clinician is that I would like to use this information for helping with patient care. And that means helping families and caregivers understand the best way to manage symptoms, helping with planning, and identifying those resources out there that actually might be useful for helping patients maintain independence and safety at home. So what happens during a typical neuropsychological evaluation? Clinically, we typically start with an interview. And here is where we actually can get a sense for what your concerns are as the patient. But I also take this as an opportunity to have in a casual conversation an opportunity to see what may come out from that more naturalistic interaction. And based on that, I start to formulate hypotheses and think about, well, it sounds as though this may be more of the issue. I'm going to focus those tests in that domain instead. And it's really hypothesis generation. And I test out my hypothesis. And then I'll give these paper and pencil tests, and it's really assessing different areas of cognitive functioning, and I'll go into that in a little bit more detail. And then from there, we generate the recommendations. What can we actually do from here? Cognitive domains. So these are typically the areas that we like to tap and assess with our paper and pencil measures, but I have to say before I go through this list, there are many in this room who may not agree with the subdivisions I'm going to make, okay? And that is a matter of academic debate, and somewhat it does have an impact on functioning and how we describe things to patients. So bear with me. I'm going to simplify it in the way that makes sense for me in my head, and hopefully it'll make sense and is much more accessible for everybody in the audience. I usually start off by talking about attention, concentration, and why is that? Attention to me is sort of the base of the cognitive pyramid. If you don't have a good base of attention, you can't pay attention to what somebody's saying to you. Your mind starts to wander when somebody goes on and on and on about neuropsychological testing. If I were to then ask you later on, what was it that I told you about neuropsychological testing, you may not remember it, mostly because you just weren't paying attention. This is me throughout school. And so how do we actually test it? And what do we, and other names that we think about when we talk about attention, concentration? Working memory. You might hear this term a lot, and I consider this one way as a mental blackboard. When you actually are trying to hold on to information short-term online long enough to do something with it. Remember this phone number, and you keep repeating it until you get to the phone that you can dial it, or maybe even doing some calculations in your head. How do you calculate tip? Are you getting the correct change, et cetera? So there's a lot that's going on online. Some of the tests that you may have seen performed in the doctor's office, things that require you to listen to the doctor read a series of numbers, and you're supposed to repeat them back to the doctor in the same order. And then after that, they'll do something very sneaky and say, well, now I'm going to read numbers, and now I'm going to ask you to repeat them in reverse order, which everybody groans at when and looks at you in horror when you actually suggest that they do this. And that is really something that one of the major ways we actually assess that mental blackboard. Can you actually hold on to those numbers and manipulate them in some way? Other tests that look at attention, and now we're bleeding into an area called executive functioning, but it's these connect the dots tests, where essentially you're asked to find numbers on a page, find letters on a page, connect them in a particular order, and look at whether or not people lose track of their thinking. Sometimes people use this as a measure of divided attention and multitasking. Can you keep track of all the information you're asked to keep track of, and bop back and forth between these pieces of information and still be able to complete the test accurately? Other areas that also require attention, something that Megan probably will speak much more eloquently about, which is word retrieval. This is a task where we might ask people to just generate words that begin with a particular letter, baby, brown, bear, butter, box, and so on, as quickly as they can. And this actually helps us not only look at whether or not somebody can sustain their attention, but can they actually retrieve information? Can they organize their thinking and structure it in a way that allows them to access the information accurately. So as you can see, I'm already evolving to talk about more than just attention at this point. From there, I build up from that cognitive pyramid, and I think about something we call executive functioning. Now, I don't know the best definition, but I think of an executive in our brain. The portion of our brain that does a lot of the delegating, organizing, actually managing lots of pieces of information. I was always taught the executive functions as the 7 S's, but I put 7 in quotes because over time, the person who made this up, Dr. Milberg, has turned it into 9 or 10 S's, but to keep the alliteration, we just continue to call it the 7 S's. And what he thinks is encompassed in executive functions: the ability to start a task, the ability to stop and inhibit, sustaining, switching between activities, selecting, and then sequencing. Self-awareness, sorting, scheduling, socializing, okay? Other ways people think about executive functions: abstract thinking, organization, planning, judgment, and this could be judgment about safety issues, judgment about social interactions, reasoning, problem solving. How do you manage this sudden emergency that comes up in the home? Can you figure out what to do in these situations? Inhibition, your ability to actually stop yourself from responding to something that you either see or hear in the environment. And motivation, and this is a big one, particularly in frontotemporal disorders, because it can help with this diagnostic clarification depending on how these executive functions play out in the cognitive profile, and I'll talk about that in a little bit. Some tests that are very popular, and I'm sure you've seen in popular literature, in various computerized brain training games, is this color and word switching test, where ultimately the task is to, as quickly as you can, don't tell me what the word says, tell me what the color of the ink that the word is printed in. So if you are trying this right now in your seats, in your head, you can imagine it's a little bit difficult. And the reason for that is our brains are a little bit more facile, and it can actually handle reading much faster and easier. It's a lot more automatic for us, as opposed to identifying a color. So as I go down that list, my brain, different parts of my brain are really competing. Should I actually say the color or say the word? And you can imagine that that's an incredibly difficult task, managing all those complex processes. When we think about what areas of the brain are involved in subserved these functions, these frontal areas. Next, we think about learning and memory. And I have to apologize because I know that I'm simplifying the way we think about memory quite a bit, but generally this is how I talk about it when I'm giving some follow-up and feedback from the testing. We often talk about phases and different aspects of memory. How do we test it? We'll say, here's a list of words I want you to remember. Try to remember them, and you're going to recall them 15 minutes later. Or I'm going to give you the list, and you'll tell me yes or no, do you recognize this? A parallel version of this can be done with visual material. And then we talk about what happens when we're asking you to learn information. The first part, some people call learning, some people call encoding. What does that mean? What's actually happening there? That's when the information is coming in and you have to figure out what to do with it. Some people try to figure out strategies for managing that information so it's a little bit easier to keep track of later on, some mnemonics, okay? And this allows you to group information a little bit differently so that's within your span of attention. Really, it helps you learn. It's about looking at how efficiently you can actually lay down those memory traces. The next thing we think about is then how do we transfer those memory traces into long-term, into storage? How do we consolidate information so that it's now in our memories and available to us later on when we need to retrieve it? And then the third part is retrieving it. Okay, so this can be a very difficult task, especially if you're having word-finding difficulties. The information is all in there, but you may not be able to access it readily. So we look at how people perform on these tests and figure out, is it an encoding problem, is it a consolidation and storage problem, or is it a difficulty retrieving it? And based on that, we can actually figure out what type of language-based problem it might be, what type of frontotemporal disorder that's preferentially affecting language as opposed to memory, et cetera. So that brings me to language. I can't even begin to speak about this in an eloquent and articulate fashion because I'm being followed by an expert in language, speech, and pathology, so I'm going to let Megan Quimby talk about it. I don't want to embarrass myself here. Suffice it to say, these are the things as a neuropsychologist I try to screen for. As we talked about already, we've tapped into accessing and retrieving language. We ask people to repeat information they hear. We try to assess how well they comprehend complicated language. Before you point to the ceiling, point to the door. There's a little bit more that you have to parse in that sentence before you can actually accurately follow the command. And then we look at writing. How do you actually translate what's in your head, the language, and into forming the words, to putting together a coherent narrative, and reading. One of the tests I really like that assesses language, among other things, is this bill paying task. And essentially in this task, what we do is we give them a fake bill and a fake checkbook, and we want to see if they can read what the instructions are. Can they actually complete the task, write out the check, complete the envelope, do the math calculations, and assess whether or not they can understand there's enough money. So this really is tapping into not only language, but all the other areas that I just mentioned, especially executive functioning. And these are the areas that we think about when it comes to areas of the brain that subserve language. Visual spatial abilities, we might ask people to copy something absurd like that and see how they approach the copy. What do they do with this figure? Do they draw the overall configuration? Do they just focus on the details? Do they integrate it properly? Other tests we might ask them to do, we'll give them a two-dimensional pattern like this, and we'll say, here are some blocks. Try to figure out how to put the blocks together to make and recreate that visual pattern. And a lot of times this will tap into difficulties people will come into the office with saying, you know, I can't really navigate as much anymore. I know I'm supposed to be going over here on the other side of the BU bridge, but I can't figure out how that fits into where I'm coming from in Brookline or Newton. So there's a lot of spatial memory, spatial integration that's going on, and I think this taps into that a little bit. Areas of the brain that we think are subserving visual spatial skills. And I want to get into mood and behavior now. This, I think, definitely deserves its own category. And the reason for it is because this is one of the defining features of something like a frontal variant, behavioral variant FTD, where you look at behavior changes and personality changes. The problem with this is that it's hard to actually assess. Mood, depression, anxiety are really partly based on somebody's subjective experience. If I say I'm sad or if I say I'm anxious about something, and that's a really subjective piece. There are also objective ways to measure it. You know, your heart rate can actually go up if you're anxious, et cetera. But it's a really difficult construct to actually get to with the types of tests that we have in neuropsychology. Right now, we do it mostly through questionnaires. We have screening measures. We actually have family and patient versions of the same questionnaire to see how they, their respective perspectives look like with respect to those particular symptoms, and then compare to get a sense for whether or not the patient has insight into these changes. A lot of it depends on caregiver report and ratings. And then the clinician has observations. When I'm sitting with a patient and you're having a conversation with them, you already start to get a sense for and have an impression about any behavioral oddities. I didn't expect that person to comment on the way I was dressed that day, and whether or not I needed a haircut, or whether or not I needed braces. I've had so many comments like that that I thought was diagnostic. And you know, we're now making strides towards really measuring this better. And one great example comes from Dr. Dickerson's lab, which is the development of the SIRS, the Social Impairment Rating Scale, which is a structured interview that takes into account not only the different domains that we think go into social functioning, but then base it on the clinical observations and the interviews that we take. How do we use the results? Well, we use it to clarify diagnosis because certain disorders have distinctive patterns of cognitive strengths and weaknesses. The functional information actually allows us to understand how these changes may affect functioning in daily life. If they can't complete that connect the dots test, does this mean that they may have a hard time driving? Can they actually keep track of more than one thing on the stove? Will they get distracted and forget to go back to taking their medications, which they were in the middle of? So we try to translate these things to these functional domains. Then we try to think about interventions. Sometimes people wonder about mind-body activities, and in fact, Dr. Dickerson and Dr. Lazar at MGH are now trying to understand the impact of mind-body activities on memory. Environmental supports based on that cognitive profile, we try to get a sense for what you might need to help you compensate so that you can actually maintain independence at home. Lifestyle changes, people often ask, well, is there anything I can actually do to improve my cognition? Is it something about my diet? Is it something about my physical activities? Is it that I'm under too much stress? Depending on how that profile looks, we can actually try to get a sense for whether or not any of those changes might actually help. And the most important factor, I think, is the psychosocial support. Once we have a better understanding of what the caregiver and the patient are going through, it's really helpful, as many of you in this room know, having others to talk to about this, having others who have gone through this disease in different phases and can offer their support and their advice along the way. And it's always helpful to just have somebody who can understand what's going on. Also, it allows us to really put people in contact with appropriate psychoeducational programs, such as the one that we have here today. Results in the research perspective, it's really, we're trying to connect these crude measures of cognitive function based on these paper and pencil tests to actual biological measures, imaging. We try to correlate it to the different types of functional imaging to get a sense for how accurately, in part, these behavioral measures are actually tapping into the areas of the brain we think they are. And I think over time, with the improvement in imaging techniques, that has really evolved and improved and become much more nuanced. Frontotemporal disorders are unique. Right now, these are the tools we have, paper and pencil and computer tasks. But the tools we need are ones that have greater sensitivity to the areas affected in frontotemporal disorders. I'm thinking about mood, behavior, functionality at home, and measurements that really capture real life, real-time functioning. As much as I am a fan of neuropsychology, because that's sort of what feeds me, I also realize that this is a snapshot in time whenever we see somebody come into the office. I'm seeing them at their best in terms of no other distractions, it's just one-on-one, so they really can do quite well, but it's not actually capturing what's happening in day-to-day life. And now that we are the generation of self-quantifiers. There are so many gadgets out there that we can actually use to capture and measure functioning in day-to-day life. Some of the things that we're doing in Dr. Dickerson's lab is trying to figure out how do we incorporate technology and leverage technology in a way that can help augment what we already get from neuropsych testing the traditional way. Some of it is remote assessment via video conferencing, getting biological measurements, heart rate, et cetera, and having that information sent remotely to servers. And then now there is a big move towards aging in place, where we're going to outfit the home with all the sensors that we can to be able to monitor safety and functionality, and to allow us to understand how well we can actually support somebody at home alone. So what to write home about? Given the digital age, we can write about this in a number of ways to home. And essentially, it's a way, neuropsychological evaluations you can think of as a way that provides a dimension of understanding the natural course of very complex conditions. It's just one way of looking at it. It helps, I think, caregivers better understand what their loved one's cognitive abilities and emotional struggles may be, give them guidance around expectations, how to accommodate, give us a sense for functional capacity, and monitor those changes over time. So I'm hoping this crash course might give everybody a little bit more of a sense of what your loved ones have gone through, since many of you were probably not in the office when this was happening. It's sort of this closed door and you don't know what's going on. That's essentially what happens. And I'm hoping that this gave you a little bit more insight into things. So I think we are not taking questions, so I'm off the hook. Thank you.
Thank you very much, Bonnie.